Good
evening. We are happy to bring to you the next edition of AIOS International Masterclass. We have this masterclass every fourth Saturday regularly from 7 p.m. to 9:30 p.m. Indian Standard Time. And today we have none other than the Lord of the Rings, Professor Boris Malugin, speaking to us on intraoperative floppy iris syndrome and cataract surgery in small pupils. Chairing the session today would be Dr. Samar Kumar Basak, who is the president of All India Ophthalmological Society. He's from Kolkata. Dr. Partha Biswas is the president-elect, and he's from Kolkata again, from Trinetralaya. Dr. Jeevan Tityal, who is the vice president, is from Api Center for Ophthalmic Sciences, New Delhi. Moderators today would be Dr. Sonu Goel from Anand Eye Hospital, Jaipur, and Dr. Suven Bhattacharjee from Nayan Eye Center, Kolkata. Manoj Mathur, treasurer of AIOS, would be assisting them. We have an eminent expert panel today, starting with alphabetically from Arup Chakravarti from Chakravarti Eye Care Center, Trivandrum, Dr. Chitra Murthy from Eye Foundation, Coimbatore, Dr. Krishna Prasad Kudlu from Prasad Netralaya, Udupi, Dr. T.P. Lahane from Raghunath Netralaya, Mumbai, Dr. Naren Shetty from the Narayan Netralaya, Bangalore, Dr. Rohit Om Prakash from Om Prakash Eye Institute, Amritsar, Dr. Sri Ganesh from Netradhama, Bengaluru, and Dr. Sujata Mohan from Rajan Eye Care Hospital, Chennai. So that covers the India, almost the entire spectrum of the country. We have case presenters also. 8 cases will be presented just after Boris' masterclass related to his topic, and there will be a panel discussion. And the case presenters are young ophthalmologists from various parts of the country. Himani Chatterjee from Trinetralaya, Kolkata, Dr. Manpreet Kaur from Api Center for Ophthalmic Sciences, New Delhi, Purnima Dhan from Anand Eye Hospital, Jaipur, Rohita Nayak from Narayan Netralaya, Bengaluru, Sindhu Saravanan, resident from Rajan Eye Care Hospital, Chennai, Sumit Lahane from Raghunath Netralaya, Mumbai, Supriya Samak from Netradhama, Bengaluru, and Dr. Zain Khatib from Khatib Eye Clinic, Mumbai. I request Dr. Samar Kumar Basak, President of AIOS, to make his opening remarks, following which I request Dr. Sonu Goel to introduce Professor Malugin.
So this is a wonderful initiative by the AIOS every fourth Saturday masterclass. And Boris, you know, everyone across the world, every ophthalmologist know you. And we are eager to hear about your presentation about the intraoperative floppy iris syndrome, cataract surgery, and small people probably will be the best terminology. So, and I welcome this webinar podium, and the time is yours, and all the time is for you only. You are welcome.
So, thank
you.
So,
ladies and gentlemen, I have the pleasure to introduce one of the doyens of ophthalmology, Dr. Boris Malugin. He is a professor of ophthalmology, Deputy Director General at the S. Fyodorov Eye Surgery State Institution. And he is the president of the Russian Ophthalmological Society, the European Society of Cataract and Refractive Surgeons. He's the board member. And he's also a member of the International Intraocular Implant Club, Academy of Ophthalmology Internationalists, American Society of Cataract and Refractive Surgery. And Dr. Malugin is an international member of the American Academy of Ophthalmology. He has published numerable literature extensively, co-edited several books in different fields of ophthalmology, and contributed to the printed and the video versions of the Atlas of Ophthalmic Surgery and the Video Journal of Cataract and Refractive Surgery, along with, I think, Bob Washer. So Dr. Malugin serves as the editorial board of the JCRS, INET, Cataract and Refractive Surgery, the Today, Eurotimes, Ocular Surgery News, iWorld, Ophthalmology. He's a chief medical officer and the editor of Ophthalmology Surgery Journal, Russia, and the Russian Eurotimes. So he's an internationally recognized expert in the field of modern ophthalmic surgery, establishing himself at the forefront of advanced cataract and corneal surgery. He pioneered what we well known, the device for pupil expansion for cataract surgery, the Malugin's ring, and several of the technologies. He is well known for his educational activities in Russia and abroad, having multiple international awards, and has participated for invited lectures and live surgeries across the globe. So ladies and gentlemen, let's hear from this doyen of ophthalmology.
First of all, I want to thank All India Ophthalmology Society. I want to thank Dr. Santosh Hanavar and all my Indian friends for the honor to join you for this webinar today. It's really a pleasure and honor to be here with you and to share some of my expertise in this topic. I believe you can see my first slide.
Yes.
Okay, perfect. Thank you very much. So I'll be talking today about intraoperative floppy iris syndrome and cataract surgery in small pupil. And you see that there is a variety of conditions that can lead to small pupil. They are age-related or related to the local or systemic comorbidities. Small pupil is not only a geometrical issue, but also one of the indicators of the comorbidities, of the eye comorbidities, such as glaucoma, pseudoexfoliative syndrome, inflammatory disease, such as uveitis, and many others. So basically, the question is what pupil we consider to be small, and the consensus here is that generally pupil that is smaller than 4.5 to 5 millimeters is considered to be inappropriate or small for cataract surgery to be performed safely and easily. Having said that, we must emphasize the surgeon's expertise. Like in this case, the pupil is small and becoming smaller. However, we can see that the surgeon was being able to manage this case quite successfully, meaning that it's not only the size of the pupil that matters, but also the surgical dexterity and experience of the operator who can manage these cases even in the presence of not optimal pupil dilation by utilizing several maneuvers such as this one, bimanual irrigation aspiration, when the second instrument is used to retract the iris and expose the areas of the capsular bag that should be approached by the irrigation aspiration handpiece. In this case, the pupil definitely not small. However, we can see that the iris is prolapsing through the main incision and has a tendency to prolapse through the side port incision, which is a condition that we now know as intraoperative floppy iris syndrome. And this syndrome is basically a triad of symptoms when the iris is floppy, the iris billows in response to normal irrigation currents in the anterior chamber. There is a propensity for the iris to prolapse through the side port or main incision, as shown here. The iris is prolapsing through the side port incision, and we can witness the progressive constriction of the pupil, which is the third pathognomonic sign of this condition. It should be recognized early, and if managed appropriately, the surgeon can do its best and finish the surgery successfully, and we see that the pupil is quite small in that case. So in this retrospective study of more than 500 patients, the true incidence of intraoperative floppy iris syndrome was established, and the percentage of that varied dependent on the intake of the medications that are used for benign prostate hyperplasia. And we know that this syndrome was first described by David Cheng and John Campbell in 2005 and was associated with tamsulosin intake for that condition. Risk factors of this syndrome is including gender, age, presence of hypertension, intake of medications, and not only the ones that are used for benign prostatic hyperplasia, but also for hypertension. And these drugs can cause decreased pupil diameter. The role of sex, it's also well established. Women have significantly lower incidence of IFIS, in this case of almost 4,000 eyes, including significant number of females and males. Incidence of this syndrome was over 5% in men and only 1.29% in women. And this is a list of the drugs correlated with the IFIS, as shown here. All of these are alpha inhibitors, not limited only to the urologic conditions, but there are other conditions that should be treated with these medications. Risk factors are including the pupil that is smaller than 7 millimeter. So you can actually kind of anticipate iris when you see that the pupil is not dilated well preoperatively. That gives you the idea that this patient will probably not dilate very well, and you can see there is a correlation with this preoperative size of the pupil and the incidence of IFIS. You see this in 5 to 7.5 diameter of the pupil gives you almost fourfold increase of intraoperative floppy iris syndrome. Of course, we know that pupils are different, and the cornea size are also different. Sizes are also different, and they vary among the races and individuals. So it is not only the diameter of the pupil we should keep on the mind, but the diameter of the anterior segment and specifically cornea. We know that alpha-1 adrenergic receptor antagonists such as tamsulosin or Flomax directly influence the muscle dilating the pupil, and you can see it is much thinner in tamsulosin subject as opposed to the contralateral subject. This is the post-mortem study of autopsied eyes. Dr. Minucci also confirmed that the sphincter muscle was thinner, as well as dilator muscle was thinner in these patients by by preoperative optical coherence tomography, and she also came up with the dilator to sphincter ratio to help again to predict the presence of this syndrome. The prevalence of IFIS varies in the literature from 1.1 to 12.6%. This is because there are different patients populations, and as you can see here, the recent, more or less recent studies showed a quite high presence of this syndrome, around 11.5%, 12.6%, and 9.09%. So basically, that these numbers may help you to anticipate the number of cases you may see in your clinical practice. Classification of IFIS is based on the severity of the syndromes involved. It has a grade 0, mild when we have only iris billowing, moderate when there is a billowing and intraoperative miosis, and severe when all three classic symptoms are present. IFIS onset, there were some reports that IFIS can be seen even 48 hours after intake of tamsulosin, and that is pretty fast given the interaction of these medication with the muscle dilating the pupil dilator. Complications rates also vary depending on the surgical dexterity of the operator, but you can see this. Some of these complications can be quite devastating, including those showed on this picture. And of course, IFIS is associated with complications, not only iris loss as shown on the previous slide, but also increased ocular inflammation, increased posterior capsular rupture rate, which range from 7 to 12%. However, with adequate awareness and proper preventive measurements, it can be reduced to reasonable numbers that we can have in our regular cataract surgery. Prevention, the question whether IFIS can be prevented. It's known that the standard topical mydriatic protocol is including different medications with different modes of action. The disadvantage of topical mydriatics is the long induction time, poor bioavailability because they pass through the cornea, epithelial toxicity, and systemic absorption and side effect. That's why the augmentation of mydriatics with non-steroidal anti-inflammatory agents showed to be quite helpful in intraoperative floppy iris syndrome, reducing the number of patients with significant IFIS to almost zero in that study. Here is another option when intracameral injection of mydriatic is being used to expand the pupil. This is another injection in patient having pseudoexfoliation syndrome, and we can see that the pupil starts to open a little bit, but then it stops at a particular moment, and it will not go any further. So definitely in that case, we will be using some other strategies to expand the pupil. This is the list of options you can have from phenylephrine and anesthetic combination, and also utilizing combination of epinephrine and lidocaine, called episugarcaine by late Joel Sugar, who was suggested this combination. So the use of intracameral mydriatics reduces the chance of utilizing additional maneuvers during cataract surgery. And there are some mydriatics that are mixed with non-steroidal anti-inflammatory drugs that can either be injected into the anterior chamber or added to irrigation solution, such as Omidria. And this medication helps to stabilize the size of the pupil during the surgical procedure. The surgical technique in small pupil cases is usually slightly different from what we get used. We like to use anteriorly elongated corneal incisions to prevent the iris to prolapse. We want to do strictly calibrated side port incision, gentle hydrodissection to avoid the iris to prolapse. During that maneuver, we utilize low fluidic parameters, emulsify the lens in the very center of anterior chamber, utilizing bimanual irrigation, aspiration handpieces. Mean duration of surgery in IFIS patients, not surprisingly longer than in non-IFIS patients. In that study published by Kaczmarek, it's 20 minutes versus 16 minutes. So it's a significant increase of surgical time. The other option would be to utilize combination of different viscoelastics, some of them used to hold the space in the anterior chamber, the others to stabilize the iris tissue, like in this technique, soft shell bridge technique suggested by Steve Arshenov, when different variations of with viscoelastic with different viscosities and adhesive properties are used during this surgical procedure. Iris hooks were suggested by our vitreoretinal colleagues. Jean de Jouan is credited for utilizing and publishing the first paper on them in 1978. And this is a very useful device, especially in IFIS when you are utilizing so-called diamond configuration, when one of the hooks is placed below the main incision, and it prevents the iris from prolapsing during surgical manipulation, specifically when you go out of the eye with your phaco handpiece. So this diamond configuration was suggested by Tom Oetting, and it's very helpful. ACF pupil expander is another option. You see this as a kind of a scissor-like device with a spring mechanism. This spring is located outside of the anterior chamber, and the device is placed into the eye through the paracentesis. And then both ends of this spring catches the iris. So there are several designs of circular iris rings being suggested during the course of the history. Most of them were based on the principle of having a groove on the outer side of the device, such as a greater ring, or having this type of device, which is hydrophilic, and by absorbing the water, this configuration becomes circular and expanding the pupil when the device is inserted inside the anterior chamber. So the groove principle is very historically is the oldest one, and there were several modifications of that. Some of them still in use in the clinical practice. The other principle of ring design is to create polygonal iris ring shape with several fixation elements. This is kind of different concept and different idea, rather than utilizing a groove located on the outer surface of the device. There are several tissue capturing elements of the pupil expander that are used to capture and hold the iris tissue. This is device that I was having a chance to design, and it is called now the Malugin ring, which is a square-shaped device with 4 circular loops in the corner. In the corners, it comes with different shapes and sizes. 6¼ is the mostly used option. 7 millimeter is used by several surgeons who utilize the divide and conquer techniques. In spite of the fact that the device is square, actually you are having a circular pupil, and the reason for this circular pupil, because there is an additional point of fixation in between 2 fixation elements. Here is number 2 that holds the iris in place. And this is the patient with intraoperative floppy iris syndrome, and we see that as soon as the viscoelastic left the anterior chamber through the paracentesis or being aspirated, the pupil starts to constrict. The iris is now billowing due to irrigation currents in the anterior chamber, and progressive pupil constriction makes this surgery challenging. And sometimes when you inject viscoelastic back, the pupil becomes wide again. And in these cases, it will be a good idea to utilize the bigger ring that will help you to manage this case more successfully, because smaller ring may not fit into this temporary bigger size of the pupil, which is due to viscoelastic injection into the anterior chamber. So you can see here that IOL is being placed and the pupil comes back to its normal shape, although we can see slight depigmentation of the iris in the area where it was pushed through the paracentesis. So this is a nice paper creating the computer model of floppy iris syndrome drafted by David Lockington, and they actually divided iris into several zones. Those are more prone for billowing and prolapsing, and those that are located further away to the periphery of the iris. And you can see here the actual modeling of the floppy iris is shown here. The iris starts billowing, and these are kind of, nomograms, color-coded, shows you how the floppiness occurs, and that's what's happening when the ring is in shape. You can still have some a little bit of billowing, but the iris is very stable to where the main points of fixation are. So the clinical reference relevance of that study is that this model demonstrated positive effectiveness of ring devices in prevention of intraoperative floppy iris syndrome. And the other significant thing, it shows how the iris is mechanically stiffened and not only dilated. Iris hooks, I think the surgical world now is divided into two more or less equal parts. Some of surgeons using iris hooks, the other pupil expansion rings. The disadvantages of the hooks is that you have a square pupil, and square pupil perimeter is longer than the round pupil perimeter. So with hooks, you have a tendency to overstretch the iris tissue, and that's why you do have a chance of higher number of atonic pupils postoperatively due to the trauma that is caused to the sphincter of the pupil. Currently, there is a number of publications and growing evidences that pupil expansion rings in general, not only the Malugin ring, but the other devices as well, are in most cases much easier to use. They require less operating time. They do not require extra incisions in the eyeball, and provide very stable pupil during surgery and minimizing postoperative pupil deformities. It's also shown. It was also shown in some publications that the rings and pupil expansion devices helped to reduce the operative time, not only for trainees, which is kind of obvious thing, but also for the expert surgeons. And iris hooks took on average 10 minutes longer than the Malugin ring for consultants, and 18 minutes longer for the trainees to complete the surgery. So this is another time factor that you should keep in mind, and when you kind of making decision what device you would like to use. So these are different devices that are currently on the market. Some of them are made of nylon, silicone, nitinol, and the other materials. So you can definitely choose whatever device you prefer to use. However, keep in mind that this is definitely more beneficial than utilizing iris hooks. And I'm not talking now about the expenses, because usually the rings are slightly more expensive, the hooks, but rather on clinical benefits that patients may have after utilizing these kind of devices. So this is the latest iteration of the Malugin ring, which is called Malugin ring 2.0. It's actually made of a thinner thread, and it's more flexible and friendly to the iris tissue. And you can see that the insertion and removal of that device is basically the same as with the classic version. However, you may have some benefit from having less stress on the iris tissue and on the pupil. And you can see that after the surgery, pupil goes back to its normal shape and size. So this is the ring that is being inserted not at the very beginning of the procedure, but rather in the middle when the capsule is open and some of the nucleus is already removed. As shown here, the ring is injected at that stage of the procedure. There is one caution to be mentioned, because when you're injecting the ring at that point of surgery, you can actually catch the anterior capsular rhexis, and this will cause the ring to be displaced, and with additional manipulation that may cause anterior capsular rhexis rupture. So you have to be very careful not to do that. These are several advantages of the newer version of over the previous one. I still love to use the classic version when the pupils are very small, fibrotic, like patients with uveitis, because they help me to handle these cases better, because you need a device that is stiff enough to conquer the iris that is fibrotic. So my take-home messages is, first of all, preoperatively, we need to check patient history. We want to use some additional medications preoperatively to stabilize the pupil. Consider using intracameral mydriatics, adjusting your flow rate parameters of your phaco machine. Use combination of viscoelastics that help you to stabilize the pupil, and utilize the ring when necessary. And I think that with the latest advances in ocular pharmacology and new designs of pupil expander devices, we should be happy with the options that are currently available for small pupil cataract surgery. And I thank you very much for your kind attention.
Thank you, Professor Boris, for that amazingly wonderful talk. And I think beautifully you have taken everything on IFIS, the wonderful ring that you devised. And I think things become very, very clear. So, Suvin, you would like to add?
Not much to add after what Boris has said. He is the authority on that. I think as we go with the videos, I think we'll have more opportunity to discuss practical problems where all of us can step in and chip in from our experience and for the benefit of the audience. If we could have the first video then by Dr. Rohit Om Prakash. Is that okay, Sonu?
Yeah. So Dr. Rohit Om Prakash is one of the leading cataract and refractive surgeons from Amritsar, and he'll be doing the video presentation, Solving the Enigma of IFIS. All to you, sir.
Thank you, AIOS, for this opportunity. Can you hear me all?
Loud and clear, sir.
Yeah, and
Slide visible.
yeah. So when I heard Boris speak, I thought that most of my job has been done because he has covered all aspects. But I would like to, emphasize a few more points so that we can take this webinar further. So, let's see this video and you will realize that the intraoperative floppy iris syndrome in this patient who was on tamsulosin is becoming quite evident right at the first go. So, there has been a study in which it has been shown that pupillary dilatation was inhibited in patients who are using tamsulosin for a pupil size of 7 millimeter or small. So even a pupil size of 7 millimeter, the risk of IFIS exists. So, as Boris has told, even 48 hours is more than sufficient. And there have been cases reported wherein IFIS has been reported in patients who have been on tamsulosin for even less than 48 hours. So it's another, a study which has been done by David Chang, wherein he has said that the use of malignant pupil expansion devices for intraoperative floppy iris syndrome, the results in 30 consecutive cases. And in this, the results were that no doubt the pupil diameter was maintained at 6 millimeter throughout the surgery when Malugian ring was used. And there was no significant intraoperative or postoperative complications. Now, the next thing which has to be borne in mind is that 93% of the eyes had moderate to severe IFIS. So we have to realize that IFIS does exist even when we use the Malugian ring or any other pupillary dilating devices. So here I would like to showcase the technique which I use, which has been propagated, of which most of it was covered by Boris, so that we can create a situation wherein we can have less amount of complications or intraoperative floppy iris syndrome severity when we use these techniques. So I would be falling short if I do not credit, David Chang for his outstanding, discovery, I would say. So let's see this patient. You will find that it's a blue-eyed patient. See the site, the incision. It's a long tunnel, as Boris had also told. It has to be a long and anterior tunnel. Epinephrine is very important, but we have to realize one very important factor, that at times when the alpha agonist they are blocked, at that point of time this epinephrine or phenylephrine works. But if at any point of time it becomes atrophied with a long usage of tamsulosin, here the epinephrine doesn't work to that extent. So this part should be borne in mind. So once that is done, I wait. Now, next is what Boris again said. So in my technique, what I'm using is, I'm in India, I'm using only a visco dispersive to my advantage. But Steve Arshinov has shown wherein he is using the TriSoft shell technique. A visco dispersive goes first. A visco dispersive goes first. Then after that, what will go is the visco-cohesive, and then the BSS. So this is what has been used, but I use a visco-dispersive. I do not overinflate the anterior chamber. Now, once that is done, a calibrated side port incision is very important. In my practice, what I'm doing is, my calibrated side port incision is such that it is a 500 micron diameter. And the side port instruments, or the chopper which I'm using, is between 400 to 450 microns, which allows me manipulations within the anterior chamber. So this doesn't allow, the intraoperative floppy iris syndrome to be initiated. So I'll show you in the video as I go along. Another important thing which needs to be borne in mind is that, as Boris has also shown, that the dilator muscle and the mass of the muscle is less. Because of which, what happens is that at times, let me go back so that I can explain it more. Yeah, yeah. So now what happens is whenever the fluidics are entering into the anterior chamber, and whenever they have access both anterior and posterior to the iris, what happens is there is increased billowing. And that is why in these patients, what we try to do is we try to create a situation wherein we create a smaller rhexis than the size of the pupil, because because the capsular rhexis acts as a shield, and it doesn't allow fluid to go behind and cause billowing in the posterior part of the iris. So this is another important thing which we have to realize. And then we have to realize that the muscle tone, the dilator muscle tone is less. And now what happens is that with a small touch, what happens is that there is the pupil constricts. So this is the rhexis which I'm trying to create. In this, the rhexis which I'll be creating will be a rhexis which will be smaller than the size of the pupil. Reason which I've already told, this is the only condition wherein in a small pupil, you try to frame a rhexis smaller than the size of the pupil. So that is the first thing which we have to do. The second thing is do not do overhydrodissection, which is the most important thing, because that can also cause, a start of the intraoperative floppy iris syndrome. So, just nudging it. The next step is, which we have to bear in mind is, I'm going in with irrigation off. So irrigation off and you go in is another very important thing which we should be very clear of. And see the fluidics, because in Lockington study, which Boris was mentioning, the low fluidics, that also causes less amount of billowing in the anterior chamber and less precipitation of intraoperative floppy iris syndrome. So go in, irrigation off, and then once you are in, you put the irrigation on. Calibrated side port instrument, you will find the chopper, it just goes in. And herein the situation is such that I'll just show you as and how I move on. You will see the low fluidics they are causing less amount of turbulence. The chamber is stable. So this is one condition wherein one should try to create a situation wherein there is less turbulence and low fluidics also help. So, I'm trying to divide the nucleus and trying to make it into, it's a very soft cataract. Just see now with this magnification. Here you will find that the chopper is not touching the iris. And this is happening because the side port is calibrated and IFIS is not being initiated. So this is something which is most of the time overlooked. I always call that, and see the emulsification is being done right in the center. As Boris has already told, irrigation off and it comes out. So once that is done, again, you will find that the size of the pupil is the same as it was at the start and at the end of irrigation off, and it comes out. So next step which we have to bear in mind is about the So this is something which we have to bear in mind. So what I'm trying to say is, so all these things have to be borne in mind when we are trying to deal in a patient who is on tamsulosin. While doing irrigation aspiration, a bimanual irrigation aspiration is required because that creates different plane of irrigation and aspiration and causes less billowing of iris and less precipitation of intraoperative floppy iris syndrome. With all these things, I think when we move around, we can create a situation wherein we can decrease the incidence of intraoperative floppy iris syndrome. As Boris has said, that in Asian population, in the brown iris, the intraoperative floppy iris syndrome incidence is less. But these were the patients in blue iris, which I showed, wherein we can decrease the incidence of intraoperative floppy iris syndrome if we manage things meticulously with a surgical plan. Thank you very much for your kind attention.
Thanks, Dr. Rohit Om Prakash. I think that was a wonderful description, video-based, of the entire gamut of IFIS. Now, Sumit, let's invite Dr. Sumit Lahane.
Yes.
Sumit, are you here? Dr. Sumit Lahane.
I don't see him logged in.
So I don't
I
think
think
he's
we'll
there.
move on to the next case if he's not
Yeah, so Dr. Purnima Dunn. So I invite Dr. Purnima Dunn. She'll be talking on.
Dr. Sumit is actually stuck in a meeting. He said he would be joining in some time, probably. Would like to present towards the end.
So wonderful. We'll have him in the later part.
Yeah.
So we will go on to the next presenter, overcoming obstacles in small pupil surgery. And I think we have Dr. Purnima Dunn. She's from Ananda Hospital, Jaipur. All to you, Dr. Purnima.
Dr. Purnima, you need to unmute yourself.
Yes.
I think my slides are visible to all of you. Am I audible? Good evening, everyone. I'm quite thankful and grateful to all the esteemed panel here to giving me the opportunity to be present among all of you and to present my journey, how I overcame the obstacles in small pupil cataract surgery and what was my experience through it. So going ahead, I will be presenting a series of cases where one patient I had was a cataract of 65-year-old male. He had history of diabetes. He was on treatment since last 10 years. He again, one more added history was of BPH, and he was on tamsulosin since last 1 year. But we didn't try to stop it because studies have shown that even after stopping the drug, the results on the iris are the same. His BCVA was 6/16 in the right eye, and the other eye was pseudophakic. In the anterior segment, as you can see, the other parameters were normal. Anterior chamber depth was okay. Intraocular pressure was okay. But the cataract grade was around -2 to 3. And the maximum pupillary dilatation, which could be achieved after maximum mydriasis, was around 4 to 4 mm, around 4 to 5 mm. 5 mm. Fundus was within normal limit, and the surgery plan was phacoemulsification with malleolin ring with intraocular lens implantation in the right eye. And this is a other case scenario. She was a 70-year-old female. She had only a positive history of hypertension on medication. She doesn't have any history of urinary incontinence or any diabetes, anything. Her vision was 6/12 in the right eye, and the left eye it was 6/24. And the cataract grading was around nuclear sclerosis grade 2, but she had pseudoexfoliation, which was the main cause for non-dilatation of the pupil. And again, in this case, it was small dilating pupil with only 3 to 4 mm of maximum dilatation, which could be achieved by after maximum mydriasis. And again, the surgery plan was same, that was phacoemulsification with malleolin ring with intraocular lens implantation. So these are my videos, which I'm going to share with you. As you can see, after making side ports and the main ports and injecting the anterior chamber with sufficient viscoelastics, I am inserting the malleolin ring. Since it is one of my few initial cases, I had little bit difficulty in engaging the scrolls of the ring in the with the iris. So I had to take help of the iris hooks to engage it properly. But ultimately it was engaged like properly, as you can see, but little manipulation was required and it caused little bit injury to the iris. But ultimately the desired dilatation was achieved. And since an anterior chamber depth was maintained with dispersive viscoelastics, mostly we use Viscoat for that to prevent corneal endothelium injury. And the phacoemulsification was completed. We use less power, less fluidics, as already explained by Professor Boris sir and Rohit sir. So, and the whole surgery was completed without much of hindrance. Intraocular lens was implanted. And at the end, when again the viscoelastics were inserted and we tried to remove this loops, the scrolls from the iris, that also I had little bit of difficulty because it was my few of the initial cases, and with the injector was again inserted, and with the help of the hook, it was tried to put it back in the injector and it's pulled through it. But in that process, if you can see, one of the loop was broken, and I tried to hold it with the help of the iris hook, but still it got released and it went through it. But luckily, since it's a very malleable structure and it's made of polypropylene, not much injury happened, and the case was completed seamlessly. This is the other one in this. Because the anterior chamber depth was a bit shallow in this case, so the leading scroll, it just went posteriorly and the sideways, but I managed to engage the side scrolls very nicely. I had to pull back that leading end, and then again it was engaged to the iris nicely, but in that process I somewhat injured the anterior capsule, as you can see, but not much complication happened, and everything was the whole surgery was completed in one go. Now, again, when I'm trying to pull back the Malone ring and trying to pull it outside, as you can see, there was little bit injury to the iris, and the other end to the nasal side is got engaged and snuck the iris, and there was little bit of sharping, which caused little bit irregular pupil the next day. Now, with time and with patience, I got the art, and I went very slowly this time. And as you can see in one ahead only, and when one go, you can see that all the scrolls are engaged very nicely in the iris plane. The anterior chamber is maintained, and not much manipulation was required with the iris hook. And again, the same thing, it came out also very nicely without much injury to the iris. And it gives us confidence also to perform with the ring, we are able to perform good surgeries in small non-dilating pupil also. So key points to take here is, for us, pre-operative assessment and history is the most important thing, because that prepares you for the surgery also, and you have to keep in mind what parameters we have to keep, and what things you have to keep in mind. Pupillary dilatation, how much you can achieve intraoperatively, and you have to be prepared that you may be required to use pupillary dilating devices, or in some cases of if you have pseudo exfoliation and if there's chance of subluxation is also there. In other than ring, you can take use of hooks also, because that gives you after the surgery, you can give support to the capsular bag also. It helps as a capsular hooks also. Then viscoelastic agents is the most important thing, because in this cases dispersive agents are mostly preferred to prevent injury, and as you can see, the anterior chamber is also reduced in all those kinds of cases in small pupils. And even they are using the ring, the vertical height is also increased, so that reduces the anterior chamber depth in the periphery. And fluidics and phaco power already discussed. We have to keep in maximum low parameters, which with low fluidics, low phaco power, low aspiration rate, with zero irrigation as well as needed. Lastly, Maloney ring provides safe, consistent pupil dilatation, and comparatively it has less stress on the iris, less injury to the iris. Not multiple ports are required. You can do it in the single port, and it is comparatively very easy to insert and remove. With experience, I learned that. Thank you.
Thank you, Dr. Purnima, for sharing your learning curve. I would say. Yeah, thank you very much. Since you showed your struggle with the ring, especially the engaging the second and the third scrolls, since we have Professor Boris over here, Boris, would you like to offer some tips to our young surgeons over here, which would help them to engage the second and the third scrolls easily? How would you like to propose that? That was an issue. I think most beginners have that issue.
Dear Suven, I think the issues that I've seen were maybe related to the fact that the ring that was used was 7mm, and 7mm ring is a little bit less straightforward to insert and remove. So I personally like, when I engage the last scroll, not to insert the ring into the iris, but rather take the second instrument, like a hook with a small bulb on the tip, and engage the iris and insert the iris into the last scroll of the ring. So that helped me to make it a little bit more delicate, more soft. With regard to the glue that was broken, yes, it's possible. It's not possible when the ring is kind of new, but if you re-sterilize it several times, there is a theoretical possibility that it may happen. So I thought the doctor was handling it very delicately and very nicely. Also, interesting for you maybe to know that one of my designs of the ring was actually open without connection in between two portions of the ring. So I was kind of using the same technique by retracting it inside the injector, this type of the ring, but we abandoned that design because the original, the one that we use now is more stable. However, that was one of the options that I was trying to do, and it also worked quite well.
Thank you, Boris. So Sonu, are we good to go to the next case?
Yeah. So we have Dr. Rohita Nayak, and the talk is on the art of phacoemulsification in small pupils. Rohita, are you?
Good evening, everyone. I thank
On to you.
AIOS team and for giving me this opportunity. And I thank Dr. Narayan Shetty for backing me.
You can start sharing your screen.
Yes, sir. Is my screen visible, sir?
Yes,
now?
your screen is visible and you're audible.
Yeah, thank you. Today, my topic is the art of phacoemulsification is a small pupil. In a routine day at our OPD, we have been referred with the young patient with uveitic cataract who has a small pupil. And I'm thinking whether I'll be able to give this patient optimal outcomes. Thinking about what are the challenges I may face in this case. So in these cases, we have a reduced red reflex. We have an increased risk of iris damage, iris bleed, iris may start prolapsing, and probably we may have a capsular excess size which can be smaller, and also difficulty in aspiration of the cortical matter and IOL implantation and alignment of toric. Even despite all the challenges, we took up the case. This is how it presented. So what are the problems we are actually seeing here? The problems we face are, there is a 360-degree pupillary membrane and 360-degree posterior synechiae, small pupil, and a mature cataract behind it. So after the side ports and the main ports, I inject viscoelastic. I'm trying to find a nick, but there is nowhere there is a opening. So I make a small nick. Oh, the fluid is there, but I don't know whether I've nicked the anterior capsule now. And if it is a very thin membrane, it normally comes out only with the microrhexis forceps. But here I needed to use a bimanual technique where I'm using a microrhexis scissors in one hand and microrhexis forceps in other, and slowly, because it's a thick fibrotic membrane, both the instruments will be required to cut open the fibrotic membrane. Care should be taken that we are cutting open only the fibrotic membrane. In case we even damage the pupillary margin, it may start bleeding, and bleeding will actually obscure the view for us. We should take care that once we have removed the posterior synechiae, we may even see subluxation of the cataract. I'm placing iris hooks in this case. I make small 4 paracentesis, retract the silicone sleeve, and engage each iris hook. I have tried to stain the anterior capsule, but because we had already put the visco, it has not stained completely. I'm using a rhexis forceps, but the problem with these kind of cataract is even the capsule is very fibrotic, and in most of the places it is stuck. So I'm using a microrhexis scissors to cut open the fibrotic bands. So, and in some places, the cortex is, the nucleus is liquefied, but most of these uveitic cataracts will be very soft. We have to take care that our phacoparameters are very low in this case. We can see the fibrotic nucleus matter also. After a thorough cortical cleanup is done, I'm just checking to see if I have actually nicked the rhexis. There is a small extension, but it is still, we are still able to place the IOL in the bag. Iris hooks are disinserted. Again, the visco is washed out completely. The case is closed. The struggle is real, but with every challenge, we can master these kind of cases. Thank you.
Yeah. Excellent presentation, Dr. Rohita.
Thank you, sir.
Yeah, it was wonderfully done. And I was looking at Suvain and Boris, who are in the other side. I'm in your
Yes.
side.
Yes.
You know, they were seeing the, fully dilated pupil like that, and, we can match them in one way, because, their pupil, which is dilated, is around 6 millimeter or 5 millimeter. So if we can dilate it to the same extent and use, 5 millimeter dilatation, while using iris hooks, there'll be less amount of, the tear in the pupillary margin.
Yes, sir. I've
Yeah.
used both the rings. I've actually used even the iNova, which has come out recently. And in this particular case, I chose iris hooks because in case if the capsule was weak, I needed to modify it as a capsular hook, and I didn't want to insert one more thing. That is why I chose iris hooks and most of my uveitic cataracts, I prefer to use iris hooks.
I use iris hooks most of the time.
Yes, sir.
So
Yes,
that way.
there are definite indications for iris hooks over the rings.
Yeah.
There are certain situations, especially if you're expecting a subluxation, if you're doing a pseudoexfoliation case and you're expecting a subluxation, there is no way we would like to use a ring. We'd prefer to use iris hooks because it allows us the opportunity to use asymmetric dilatation, and you can choose the clock hours where you want to, work on the subluxated areas. So those are certain advantages. But all said and done, what happens, Rohit? I'm not trying to disagree with you. I'm just trying to bring out an important point is that the corner spaces that you are, whatever size you choose,
Absolutely.
the
I
corner
agree with
spaces
you.
are wasted spaces.
Yeah.
So
It's-
you are causing a little bit more stretch than a circular pupil or a hexagonal pupil, whatever ring you use. So, I mean, that's a matter of it's not really a debate that we want to go to. We always want to encourage surgeons to use whatever they are most comfortable with and
Absolutely.
what works affordable also. That's also a concern always in our patients.
And if the anterior chamber depth is less than 1.75, that is also one of my indication for using iris hooks.
Absolutely, absolutely. Because you just have to pass the hook. You don't need any other device to go into and manipulate. Partha, would you like to add something?
Yeah, thank you, Shwen. So all is said about the expanding this uveitic pupil. Maybe one or two things, if I can add to Dr. Rohit's very nicely presented video. That is the staining of the capsule. So in these capsules, especially if it is a white cataract or even if it is not a white cataract, need to be stained well. And because if you put in the viscoelastic and high molecular viscoelastic immediately, then the stain becomes difficult later on. So staining it first, and at times, if you can put in the stain and then inflate the anterior chamber by a little bit of hydration into the wounds, then the stain actually percolates throughout the anterior capsule. So
Yes.
once you have stretched it nicely, then the anterior capsule is well stained. Otherwise, you'll have a small stain in the center of the anterior capsule, and you'll not be able to see the anterior capsule in its periphery. So that is one small trick that we use before putting in the viscoelastic, placing in the trypan blue and injecting, hydrating the wound a little so that it percolates. So that's just one thing that I wanted to add to
Yes,
you.
so,
Very nicely presented video.
Thank you, Partho. Thank you, Partho. One thing I could add, see, the tendency to use viscoelastic is because you want to release the synechia.
Yes, sir. That was the
Okay,
360
so-
degrees synechia. In
Yes,
this
so you feel that if you use a spatula and the AC collapses, you will hurt one of the structures. Now, a good way of doing that is use your irrigation. Use just your irrigation to maintain the anterior chamber, and you use one side port for the irrigation and the other side port for your second instrument or spatula to release the synechia. That way, once you freed the pupil margin from the anterior capsule, now you have an area where, as Partho said, we can use trypan blue in the center and a little under the iris. One word of caution, we need to be very careful that we don't overzealously inject under the iris, because that will trickle through the zonules into the vitreous and you won't have a very nice glow. And the patient will also have a little bit of difficulty for 24 to 48 hours. Thank you very much, Dr. Rohita, for allowing this opportunity for discussion.
Thank you.
If we are ready, is Dr.
Thank
Himani
you,
ready?
sir, for spending
Dr.
time with
Himani, she's going to present on toddling steps with rings and hooks. Good, let's all learn. Dr. Himani is from Trinetralaya and a promising young surgeon. Let's see what she has to teach us.
Good evening. Am I audible?
Yeah, your slides are visible and you're audible. Go ahead.
Thank you. So very good evening, everyone, esteemed chairpersons and panelists. Thank you for giving me such a great opportunity to be presenting my case in such a big platform. So I'll be presenting my toddling steps with iris hooks and BHEX ring. So this is my first case and my first experience with BHEX ring and iris hooks. It is my honor to be presenting this in presence of Dr. Shubin Bhattacharya sir. Please forgive if any mistakes I have made.
I'm honored.
So this is my first case. So this was a 65-year-old male with a history of Tamsulosin intake, with a 3 mm size pupil and a cataract grade of nuclear sclerosis 1 with posterior subcapsular cataract, which did not have any effect on viscomydriasis. So the patient had other eye IFIS. So I decided to go ahead with a BHEX pupil expander device. I introduced the BHEX into the anterior chamber gently and started tucking the arms into below the pupillary margin with Sinskey hook. The first and the second arm went quite easily, but the third arm was proving to be difficult because of constant kinking. As you can see, I was quite struggling with the third arm. So I decided to abandon the Sinskey hook technique and decided to use forceps instead, using the bimanual technique. So with the forceps in the left hand, I just gently pulled the BHEX arm, and the Sinskey hook was used to gently lift up the pupillary margin so that the BHEX arm just tucks in inside the pupillary margin. So this proved to be quite successful. And I got a pupillary size of around 4.5 to 5 mm. So the capsular rhexis, I expected it to be quite a bigger capsular rhexis, but it turned out to be a smaller rhexis. But since the nuclear grade was not that hard, so I decided not to extend the rhexis and continue with the phacoemulsification. So the second challenge which I faced was that the phaco probe was getting stuck in the BHEX arm. So what I did was I supported the phaco, the BHEX ring with the Sinskey hook, and gently introduce the phacoprobe into the antechamber. The rest of the phacoemulsification surgery was uneventful, with the BHEX ring very gracefully protecting the pupillary margin from getting aspirated into the phacoprobe. I increased the rhexis margin size after introduction of the IOL into the bag so that it does not overlap with the optic of the IOL. Removal of the BHEX ring was comparatively easier than its introduction. AC wash with diluted triamcinolone acetonide was given to prevent the post-op inflammation. So my second case was of a 70-year-old male with a history of tamsulosin intake with mature cataract of a pupil size of 4 mm diameter. The other eye had iris atrophic patches with pseudophakia, so it gives us an idea that the surgeon must have had a difficult surgery. But since I needed a larger diameter size of the pupil, I went with iris hooks in this case. So this is also my first case with iris hook. So I made 4 paracentesis, 1 mm size, 3 clock hour apart approximately, and started placing the iris hooks. I had planned on a squarish size of the pupil, but it did not turn out to be a square one, rather a trapezoid one. So 5.5 to 6 mm capsule rhexis size is made. The phacoemulsification part was quite uneventful with a good low fluidic parameter. But during the cortical wash, I saw some amount of iris prolapse from the main port. So I decided on placing the IOL and then removing the iris hooks. And then Tricort AC wash was given to prevent postoperative inflammation. And finally, the iris was reposited, which had already lost its tone due to constant handling. So this was the post-op day 1 with the BHEX ring case with a BCVA of 612 and a mild AC reaction of cells 1+. So the take-home message which I learned was preoperative planning regarding the pupil size, the maximum dilated pupil size, the grade of the cataract, and the type of pupil expanding device should be decided preoperatively. And intraoperative techniques such as low fluidics and phacopower and using high molecular viscoelastic substances rather than dispersive viscoelastic should be used. And my learnings from the BHEX ring case was I should have aligned the BHEX arm away from the main port. So this would have helped me with like when I faced the second challenge that the phacoprobe was getting engaged with the BHEX arm. So that would have helped me to avoid this complicated problem. And with the iris hook case, I think diamond shaped iris hook alignment would have prevented the iris prolapse during the cortical wash. Thank you.
Thank you, Dr. Himani. Wonderful cases, and I'm sure we'll have a lot of learning from this. It's always challenging to show your complications, and it's actually very brave of all the surgeons over here who are showing their complications and their learning steps. We're thankful to you for helping the other surgeons learn from your experiences, mishaps, whichever way you put it. All of us have been through it.
Thank you
So
so much.
it takes a lot of courage to show this. Okay, so let's begin with, let's say, the BHEX ring, where you struggle with the third flange. We call it the flange. Now, why would you think you had a trouble over there? So that it is important to analyze and see why did you have that trouble with the third flange?
So must be the reason, like I should have placed the BHEX like the first flange would have been just in front of the main port, like in front of the parallel, like.
No, what I'm trying to ask is, we are struggling with the third flange. We
Yes,
could
sir.
not bring it centrally enough to tuck it in with the Sinskey hook.
Yes, sir.
Sinskey hook is a no-no. I always recommend the forceps because you have much more control. With Sinskey hook, it's good when you put it in the hole, it's going to turn.
Okay.
The flange can swing around, like twist around like a seesaw. Okay, you got no control over it.
Yes, sir.
But if you hold it with the forceps, you got full control over it, and you can draw it in any which direction you want. Now that apart, I think it was a little rigid pupil. You see, when you have a rigid pupil, your circumference is fixed. So when your circumference is fixed, try as much as you may, you will not be able to tuck the flange. So, and you have poorer control with the Sinskey hook. With the forceps, you have better control, so you can draw it and still tuck it. The excursion can be longer, and you can bring it more centrally. If the pupil is rigid and you still manage to tuck the B hex, you will have a slight, buckling of the B hex, and the pupil may become small. So if you can identify in advance whether the pupil is rigid or elastic, then you can just stretch it a little bit. See, you have to choose to stretch the pupil. If it's a fibrotic pupil, it's not going to be like a rubber band. It's not going to be elastic. So you will have to stretch it either with 2 Kuglen hooks or the device. Now, Mulligan ring or the eye ring are a little bit stiffer than the B hex. They have more mechanical strength. So they can kind of stretch the pupil or tear the fibrotic pupil. With the B hex, I'd rather prefer to stretch it a little bit to about 5 millimeters with the 2 Kuglen hooks, and then you place the B hex, your life becomes a little easier. Right?
Just to make the sphincter lax a bit.
Yes, you have to have enough circumference for the device to engage. Right? And the part about your flange coming under sub-incisional flange, that doesn't matter actually. You just deepen the AC with a little bit of visco, and your phaco probe will go in easily. And after that, you won't even realize where you're operating.
Yes.
It's just that since it's a first case, it was difficult for you to understand and I'm sure as you go forward, you will find that it's going to be easier. Every surgery, whether it's Mulligan ring, B hex, or the iris hooks, as you go on, you just get better with it. Thank you for that case.
Thank you so much, sir.
Partho, your mentor is here. So any words of advice?
You have said it all, Suben. So she wanted to present her better cases, but I said that present your first cases. So, it would be a learning for every one of us. And these are the small troubles that we face in our initial cases, which of course go away when the better cases come in. The next cases come in. So I think what you have said is absolutely correct, Suben.
Thank you. And I think we must be thankful to all the young surgeons over here who are presenting their complications or difficulties. We learn from them. And they're offering us an opportunity to learn at their expense. Very magnanimous of you. Thank you.
Thank you so much, sir.
Right, Sonu, shall we call in now? I think Sumit Lahane is here. I think he's just rushed in. So Sumit, you can take a little bit of breather. Sumit, you can take a little bit of breather, get composed. And whenever you're ready, just drop in a message and we'll have you in. I think Supriya is ready. Dr. Supriya Samak.
Dr. Supriya, are you?
Yes, sir. Yes, sir.
Yeah. So
Can you
let's
hear
have
me,
you
sir?
speak.
Yeah. Can we have Supriya now? And then Sumit, meanwhile, you get yourself all set and then we'll have you in. So we have young dynamic surgeon, Dr. Supriya, and she'll be talking on the Mulligan ring misdemeanor. All to you, Supriya.
Good evening, everyone. It's such an honor to be here on this platform. I would like to thank AIOS and Dr. Santosh Honavar for inviting me to present a case here. And it's truly an honor to present a couple of cases of the Mulligan ring in the presence of Professor Boris Mulligan. So these are 2 cases actually where what actually happened was the scrolls of the Mulligan rings gets lost under the iris. So the first case here, this is a patient who was on tamsulosin and had a small pupil. So for this particular patient, I decided to use a Mulligan ring. As I'm inserting the Mulligan ring, it's simple enough, the insertion. However, the second scroll doesn't get engaged. So I just insert a little bit more viscoelastic and engage it through the side port. I've made only one side port on the left side, and the phaco was normal and uneventful. However, the iris starts prolapsing after the cortical removal, in spite of there being the Malagin ring. So what I'm trying to do here is I'm trying to reposit the iris, and inadvertently I disengage the subincisional scroll. So what's happened here is that the subincisional scroll has gone under the iris. So I reposit the iris and inject some viscoelastic above the iris. Sorry, I think I can.
Yes, I was going to suggest
Yeah,
that.
it was not on
disturb-
slideshow. Very sorry about that. So yes, back to this point where I'm just injecting some viscoelastic. Yeah, this is where the scroll gets lost under the iris. So I reposit the iris, and I'm just injecting some viscoelastic above the iris so that I can keep it in place, because it's already become quite floppy and the tone of the iris is lost. So I decide to first insert the IOL and then look for the scroll under the iris. So what happens generally if we blindly look for the scroll under the iris, it could cause damage to the capsular bag or the zonules. So here, what I'm trying to do is I'm just trying to move the ring a little bit so that I can visualize the scroll. I'm not repositing the iris again because I want a little bit of visibility in that area. And to make it a bit easier, I'm using a second instrument, a second Sinskey hook. But because of the atonicity of the iris, it goes back underneath the iris. So this is the second attempt at the same thing. I'm just moving the position and dialing the Malagin ring itself a little bit so that I can find the scroll and then engage it onto the iris. So instead of blindly looking for it under the iris, this technique of using two dialers or Sinskey hooks can be quite useful to find the scroll. And then the removal of the ring is quite straightforward and simple beyond that point. So this was my first case. And after that, of course, the reposition of the iris may be a little bit difficult. So it's important to probably make sure there's no fluid misdirection under the iris and avoid further prolapse. This is another case where a similar thing happens. This is a uveitic cataract. And the insertion of the Malagin ring is fairly simple. Both the scrolls get engaged. This is a case done by Dr. Sri Ganesh. The scrolls get engaged and the phaco is uneventful. The lens is in place, but while removing the iris hook, what happens is it gets lost again underneath the iris. So what's being done here is the second scroll is actually disengaged and the iris hook is trying to be dialed or rotated. And the second scroll, at this point, the second scroll also goes under the iris. So at this point, two of the scrolls of the Malagin ring are under the iris. So at this point, again, viscoelastic is injected. Magnification is increased a little bit. And a collar stud dialer is taken to actually rotate the Malagin ring. Dial the Malagin ring and rotate it from underneath the iris and bring it into the anterior chamber so that all four scrolls are visualized. And after that, the removal again with the same injector, the removal is done by engaging the first scroll and the rest of the scrolls come in as per usual. So these were just a couple of scenarios and a couple of cases where the scrolls can get lost under the iris, and two techniques of managing them, a bimanual technique by using two dialers and another technique where it's dialed into the anterior chamber to visualize the scrolls. So thank you very much.
That's so nice, Priya. Really wonderful. Can we have a quick
so
Professor Boris on how to retrieve if one of these scrolls go underneath the iris? I think very nicely Supriya and Dr. Sri Ganesh has demonstrated that. Any quick teaching pearl from you, sir?
I think I would like to add 2 points. First is the appropriate instrumentation. because to manage because Dr. Supriya tried to engage the scroll with the Sinskey hook, which is not a good instrument to use because it's kind of, easy to slide. The scroll easily slides from that. So for that, we specifically designed with Bobby Osher the Malugin Osher ring manipulator, which is having a bulb at the end, and that kind of device will definitely 100% prevent what was being happened. On the other point, I think she managed it very nicely by rotation, which is a good option. I sometimes like to use the instrument that is a hook to retract the iris and to fish for this scroll whenever it is under the incision or anywhere. And I think this is another option. And probably the third most important point is that the ring can stabilize the iris. However, the periphery of the iris, which is floppy, still mobile, and it can come to your incision, or it can come to the main or side port incision. So the ring does not address the issue with the periphery of the floppy iris, but it addresses the issue of the pupil in that floppy iris syndrome. So that's definitely should be kept in mind, because overfilling anterior chamber with viscoelastic, and specifically when you inject under the iris, will bring you what happened in one of your cases. So that's my good point.
There is a very simple technique of retrieving any loop which has gone behind or a scroll. If you've seen the tire repair guy, there's something called the tire iron technique. You will see that the rim of the tire, that the metal rim, he keeps putting a kind of screwdriver-like thing and keeps either elevating one side of the rubber. So if you take a second instrument and push it under the ring and over the iris, wherever flange you're seeing it. In your case, on the right side, you had a flange. So the flange or the scroll, just under it, you put the second instrument and just draw it towards your main incision. The iris will slide under the ring ultimately, because it's got nowhere else to go. It's got nowhere else to go. That's called the tire iron technique. I mean, that's used in a lot of surgery. Okay, instead of pulling the iris or pushing the ring or whatever it is, or hooking it, you just pass a spatula or a second instrument under the iris. Basically, the pupil margin kind of negotiates, and it has to go nowhere else but under the ring.
Absolutely. Thank you so much for those tips.
I have one more point to make. Sometimes the pupil can get very small, and if all four of the rings have gone under the iris and the pupil becomes very small, then it is a problem. Suppose you have a 2 millimeter pupil and the ring disappears under the iris. That's when the real challenge is to remove it. So in such cases, what you can do is you just try to get one of the scrolls out into the antechamber and then cut the ring. Once you cut the ring, then you can grasp one end and just pull it out. This is the least traumatic, because if you try fishing for the ring under the iris and in a very small pupil, it's going to traumatize the iris even more. So this is a simple technique where you can just retract the iris, find one of the scrolls, hook it up with the Colested dialer, bring it into the antechamber, cut the ring, and then just hold the cut end and then just pull it out.
So I think
I have another option. Just leave it like it is. So leave it in the posterior chamber. I'm joking, but there was a publication. I think the doctor from UK who experienced expulsive hemorrhage during the cataract surgery when the ring was in place. So he actually stopped the surgery, closed the wound, and then postponed the surgery 1 week. So the ring was still in place this 1 week. And then he 1 week later, he came back to the operating room when the situation was calm, removed the ring, and finalized the surgery. So if you experience such a kind of devastating thing, so it's not a harm just to stop, leave it as it is, and maybe find an expert surgeon to help you.
That's another point I wanted to make, that the floppy iris, again, see, there are some common points. So in a smaller pupil, older patient, smaller axial length, shallow antechamber, patients who are hypertensive, there's a high risk of expulsive hemorrhage. I've had 2 cases of an abortive expulsive hemorrhage while doing phaco. And this is the case where the pupil also constricts, and then you suddenly start having iris prolapse. So it may not necessarily be an IFIS, but it may also be an abortive expulsive. Because in a pressurized eye, the frank expulsive hemorrhage kind of a picture may be rare, but it may start with prolapsing of the iris. So if you keep fiddling and trying to push the iris in, then it will go in for a full-blown expulsive. So that you should keep in mind, especially when you're operating on an elderly patient, shallow antechamber, smaller axial length, hypertensive, maybe with glaucoma. So this is something that you need to keep in mind. If the iris starts prolapsing, then you also have to look out for expulsive hemorrhage.
I add one point to your comment, because when it's expulsive hemorrhage, you have to listen to the patient, because usually the patient is complaining on pain. So if he or she complaining that the eye become painful, so that's an alert for me that it probably the expulsive hemorrhage. If there is no pain, so kind of then you have to kind of room to move forward with the other manipulation. But when it's pain, so you definitely have to
pain
consider.
And alteration of the glow, fundal glow gets altered. And
Yes, Sujata, you wanted to say something.
I think take a quick comment from Dr. Sujata, and then we'll have Dr. Sumit. Meanwhile, you get ready with your presentation. Yeah, Dr. Sujata, quick comment, please. You need to unmute. You need to unmute, Dr. Sujata.
No. If in a situation like Supriya showed, is it possible for us to use the same retriever and use the leading scroll for removing the ring? How will it work? Leading or the ones on the side? Because once you
yes, ma'am. The one which has gone, the leading scroll, ma'am. So I think this particular ring is a bit too stiff to manipulate it that much in the AC, if I'm not wrong.
I don't know. Because I've never had a situation like this, but I just wondered whether, because you're able to see all the other 3 scrolls, and why not use one of them to unfold, because it folds very nicely. Usually once you get hold of it, it comes out very well. So probably with others who have an experience should be able to comment on this.
Ma'am, if I can, ma'am, actually, if you hold the leading part, ma'am, it's going to tilt the lens complex, because then there's a chances of the zonules breaking while we're trying to pull it back. I would, but that's the only thing I would say, ma'am. And also I would like to add that, is it okay if I add some few points on the IFIS, which I think everyone has shared excellent points. And what I would like to add is one small tip is, orienting the phaco holes, the irrigation holes, vertically would reduce the chances of fluid going under the iris and then, it getting pushed up. That is one of the techniques which I normally use. And also what I also do is I increase the tip exposure. That means I'm keeping the irrigation holes of the phaco probe more up and above the iris. Otherwise, what happens is when you're trying to phaco, the holes are below the iris, and that again pushes the iris continuously out over and above, the other wonderful techniques, the triple soft shell technique, and those are all fantastic, where you can always, push the iris down. And one more way is if at all by chance we're operating on a smaller pupil, one more wonderful technique is if you're not using the expanders, because a lot of experienced surgeons don't use expanders and they do surgery, is to use a 45-degree tip. But while you're doing a quadrant removal, the tendency of the iris or the pupil margin getting into your phaco probe is very often. So the trick here is to use a 45-degree tip, but while you're emulsifying the tips, you face the bevel down so that once the piece goes and there's no pupil, there's no iris below that to go and get engaged. These are small tips which I normally use during these.
I'll just add, Supriya, Dr. Supriya, how could
Yes,
you
sir.
have avoided in the first case, the scroll going behind the iris?
So I
You use a particular technique
inadvertently
from the side
use
port.
the
You use the
yes,
same instrument from the side port. Would you have,
yes.
with hindsight wisdom, would you have done this
Should have
differently?
used it through the main incision itself. That would have probably avoided inadvertently removing the scroll. Absolutely, you're right.
Or you could have even actually let out a little bit of visco from the other side ports.
Yeah.
And this knuckle of iris would have actually gone back, and it would have been easier to reposit the iris through the incision where it's prolapsed.
That's what I did while hydrating. At the end, I realized I should have decompressed the anterior chamber a little bit, let some visco out, and then on top of the iris, just injected the viscoelastic.
We could see you got wiser as you did the case.
And I think
technique what she used was really amazing, actually. Very nicely, you retrieved that particular, which is which went below the iris. But
thank you so much, sir.
One small trick is to reduce the pressure and then use I would say a visco dispersive. I was seeing that visco, HPMC was used.
I was using HPMC.
So that has a it doesn't have that good effect in pushing it back. So I would say reduce the IOP, and then from the side port you go to just below the main incision and inject a little bit of viscoat or basically any visco dispersive. I think that will do the job.
I think thank you very much for enlightening.
Thank you so much.
The presentation, Supriya. So now we have Dr. Sumit Lane. Let's hear from him. Managing small pupils, no hooks, no rings. All to you, Sumit.
Very good evening, everyone. And I would like to thank Dr. Santosh Honavar sir and AIOS for giving this huge platform and opportunity to present in front of Professor Boris himself. So these are the cases that I'm showing with doing a cataract surgery in small pupil without hooks and rings. I'm not against use of it, but I had these cases which we had done in a peripheral center where I had no availability of this. It is a case of small pupil where I'm trying to stretch. This is just a grade 2 to 3 cataract, doing a gentle hydrodissection. Now with the phaco, the most important is cutting into the two parts, and I'm trying to do a vertical chop. Here my chopper is doing both the work. It is working as an iris hook, stretching it, and at the same time even cutting the nucleus. Naren sir has made my job easy by providing those tips that you use a bent tip and try to avoid taking the iris and the iris shafting. Of course, that is a fear when you are doing in this small pupils. You rotate the nucleus using a good fluidics, and of course adjusting your tip helps in such cases to maintain your anterior chamber. Of course, we need to put viscoelastic multiple times during this because of the crunch of the time I edited that video. This is complete a safe zone phaco. Followed by this, there is one more case. Again, this is a small pupil with synechiae, almost 360 degree. I'm breaking the synechiae to open up the pupil as much as possible, but still it does not open to the complete strength. This kind of iris is much floppier compared to the otherwise a small pupil. This had complete synechiae, chronic uveitis case. It was much difficult to manage iris in this case compared to the previous one. With my sheer luck, it was just a grade 2 cataract which I could easily emulsify. You can see that I am trying to use my blunt chopper as a iris hook. Cortex aspiration takes its own sweet time because again it is a bit difficult job here. And that's it, sir.
Thank you, Sumit. I think, yes, in the adverse of conditions, when you don't have anything, I think your technique works very well. So, quick comment from Dr. Partha.
I disagree with you, Sonu, and I will court martial Sumit right away. We have
Next court martial, sir.
Yes,
many of the surgeons must have done this way before there was any discovery of iris hooks on the.
So I think he was lucky since it was a grade 2 cataract, a soft cataract in both the patients.
So I think, Sumit, on the serious note, I think whatever you showed is absolutely doable. It is something that can be done. One thing is, of course, if you have a grade 2, grade 3 cataract, which is easily, with the first chop dissects it, bisects it, then you have a lot of convenience to get the whole nucleus out. Whereas if it is a soft cataract and you're not able to do a direct chop in such a case, then it becomes very difficult. And especially if it forms a ball, then that ball and the small pupil will all crowd down and sit on it. And then it becomes very difficult. And then you'd have to use manipulators to see where you can actually flip in the cortical matter as well as the nucleus ball. So the other thing, of course, Sumit, I'm sure you will agree that at any point of time when things are becoming difficult and you're not able to manage the nucleus removal, then at any point of time you can put in the devices. You can put in the BHEX, so you can put in the Mulligan ring, and you can put in the iris hooks. However, because the rhexis is well done, so you have to be careful that the rhexis doesn't get caught in the devices. So leaving apart that, if the other problem at times is, since you're using high molecular weight viscoelastic, and there can be little pieces of nucleus which get entrapped in this high molecular weight viscoelastic and sit maybe away from the pupil, under the pupil in the sulcus somewhere. And this post-operatively can float out and cause iritis for a prolonged time, and you finally see it's in the angle of the anterior chamber. So 3 or 4 things that I just thought that would be pertinent in these cases that you have shown. But of course, your surgery is excellent, and kudos to you.
Can I just have a quick comment from Professor Boris? So in the second patient that he showed, patient with posterior synechia, so what do you recommend, which is, the ideal way to, manage these synechial patients, because they can vary from maybe just as small as 2 millimeters pupil?
I have 2 comments on that case. First, I think we should consider, as I mentioned in my presentation, not only the size of the pupil to guide us, but also the biomechanical properties of the iris tissue. In that case, where the pupil was fibrotic and probably uveitis kind of, may happen in this patient before. So the pupil, the iris was quite rigid, and there was no billowing and prolapsing of the iris through the side port incision or through the main incision. So the pupil was small, but the iris stable, and that make the surgery more successful in that case without any kind of devices. So, so my point is to judge not only the size, but also the properties of the iris tissue. Coming to your question, how to address the posterior synechia, I usually do it with a fork-like instrument. So I kind of push it, and it's quite easy to remove this synechia. It's not a big problem. The problem is when you have a retropupillary membrane that constricts the pupil. So then you need this stretching maneuver. By stretching the pupil, you're actually breaking the synechia, and also you're breaking the sphincter muscle. So that's inevitable in these cases. So you damage the sphincter muscle, but there is no other way of expanding the pupil. And sometimes in these cases, there is no sphincter muscle because it's transformed into the fibrotic tissue already. So you don't really have any concerns about damaging the muscle because it doesn't exist anymore.
Should I add something, Dr. Sonu?
Yeah, please.
At times, small pupil is associated with in patients like pseudo exfoliation. In these patients, you have to be over zealous in using dilating aids like iris hooks or whatever you want to use, because in these patients, if the pupil is small, if you try not to use dilating aids, so you can end up with a catastrophe. So this is one indication in my practice wherein if there is pseudo exfoliation along with what do you call a small pupil, because pseudo exfoliation patients usually are associated with a smaller pupil. And if by any means you find that the ACD on both sides is asymmetric, even with the same axial length, so this is one condition where one should, I saw Boris doing phacoemulsification without using aids with even a 3 millimeter pupil. But here, even with 4, if you can, you should use a dilating aid.
So I think, yeah, that's a nice comment. So anything that you want to add, Naren?
I think that's the same tip which I was mentioning earlier, sir, that I just want to add up. If you have your bevel facing sideways, when you're trying to eat up your pieces, you have a tendency for the pupil going into, especially if you're not using any of the expanders. So the small tip is you direct the bevel downwards while you're eating, so that once the piece gets into the phaco tip, then there's no iris to be caught. So that's a small tip I would suggest, but it's good to use expanders whenever it's necessary. But it's absolutely surgeon dependent, because every surgeon has his own style of performing on doing surgery.
So thanks, Sumit. We have now Dr. Manpreet Kaur, and she'll be presenting on toric IOL in a small pupil. Manpreet, are you there?
Yes, sir, I'm here. I'm just opening
Yeah,
the
please.
presentation.
Over to you.
Yeah. Yes. A very good evening to all of you, and thank you for having me here as a part of this program. I'm audible?
Yeah. Audible and
You need to
visible.
be a little louder.
Okay. I'll just try to maximize the volume. This is better? Yeah. So phacoemulsification and toric IOL implantation in small pupil is what I would be covering. There are no financial disclosures. So we have seen beautiful small pupil surgeries throughout the evening. So in toric IOL, what is more important is one rhexis, one IOL alignment, and then the post-operative assessment. Rhexis, if you have a small pupil, which is not that small as in this case, you can easily get away with an adequate rhexis even if the pupil further decreases in size during surgery, and it is adequate for toric IOL implantation. But if you look at the second case on the right-hand side, there is a small pupil and we can release the synechia with the cannula and a Sinskey hook and perform a good enough rhexis even in a small pupil. The only disadvantage is in premium intraocular lenses, if your rhexis is not the adequate size, the post-operative contraction, fibrosis, etc. may lead to slight amount of IOL tilt or decentration, which even if you get away with it in a monofocal IOL, in premium intraocular lenses such as toric, multifocal toric, may not be the best idea. So if you have synechia and a small pupil which will not let you achieve an adequate rhexis, maybe a good idea, even if you think you can successfully do a phacoemulsification in this size pupil, would be to insert hooks, and the rhexis in toric intraocular lenses should be an adequate size of at least 5 millimeters. Then toric intraocular lens alignment. You can check the alignment in a small pupil with Sinskey hooks, cannulas, or with eye movements, or you can use iris hooks along the axis of the IOL placement. A complete OVD removal beneath the IOL is necessary after aligning finally, so that when you're taking out the probe, the movements in the final wound hydration steps are minimal, as you may not be able to recheck it in cases of a small pupil. And image guided systems, of course, can be very useful. So these pupils again are just within the marks of the toric IOL that are seen on the IOL optic. And we can use Sinskey hooks and movement of the IOL probe to see in this case that you can see the three dots on either side of the optic to align the toric intraocular lens, since the hook aids in that. In the second case also, similarly, the IL optic, even though not completely visible, you can still see the three marks and align the IOL adequately along the required axis. However, sometimes even though you have done a successful phaco in a small pupil, once you go to implant an IOL, the pupil is now so small that there is no way you will be able to see the marks. So you can put in two iris hooks along the axis of the target toric IOL implantation. And this also had an ocular surface disease and hazy cornea. And I go in beneath the intraocular lens to remove the OVD, because once we align after removing the OVD, I hope that it will remain stable, and then the final wound hydration can be done after removing the hooks. Image-guided systems, as I said, are a useful aid to help align the IOL. Post-operatively, again in a small pupil, you will not be able to assess if there is any residual refractive error. Is it due to a rotation or is it due to some other cause? So iTrace toric enhancement software can help in assessing the alignment objectively, even if you cannot see the alignment marks on retroillumination in the slit lamp. So it will also give you the direction and magnitude of rotation relative to the current toric IOL position. So just to summarize, a continuous curvilinear capsulorhexis of adequate size is essential in toric IOLs. Even if you can do a smaller rhexis and phaco, do aim for a proper size capsulorhexis. Nuclear emulsification, we have seen beautiful videos throughout the evening. Avoid iatrogenic iris trauma and central safe zone to do the nuclear emulsification. IOL alignment, iris hooks, eye movement, Sinski can help check alignment. Complete OVD removal, very importantly, beneath the IOL as well. And post-operative assessment, ray tracing aberrometry is a useful aid when you really cannot see the alignment marks. Thank you for a patient hearing.
Thanks, Dr. Manpreet. I think I remember Dr. Sri Ganesh marking the IOLs. So I think any quick comment from Sri for,
I think that's a very nice device which you can use in small pupils, because it's a Ganesh toric IOL marker. So it makes a temporary impression on the center of the lens. It's got two windows which you can align to the three dots on either side of the lens. Even before implanting or loading the lens, you just press down with the marker, and then you get a indentation on the center, a line, and then you can load the lens and inject the lens. The mark stays for about 2 minutes. So that's enough for aligning it with, you can use any image guided, or even if you have a any other manual marker, and then that's very useful for small pupils, especially if you have a pupil which is just 2 or 3 millimeters in size, then it becomes very difficult to check the orientation. So this is useful for small pupils. It's available with Epsilon.
Basically, it boils down to whether you go with Ganesh, Malugin, or B. You have to choose one of them.
You have to use the right instruments to get the right result.
I think, but she rightly pointed out that using two hooks just along the axis, I think that makes quite a sense, so that you can actually dial the toric lens in that axis. So I think that's a wonderful technique, Manpreet. And I remember Dr. Kumar, devising on the irrigation aspiration. So his aspiration has a hook by which he can actually retract the iris and actually dial the toric along the desired axis. So I think during that intraoperative phase, when you're really in a trouble, I think that also makes quite a sense in toric IOL alignment. So all in all, I think Manpreet, wonderful presentation, and I think very nicely highlighted the various stages at which you can find the difficulty. I think Dr. Tyal is there. Dr. Tyal wants to make any quick comment on Dr. Manpreet. Partha, would you like to add on your?
Yeah, should I add a small trick?
Yeah, please.
And that small trick is, what should be done is, if you are using a coaxial while doing IA, you just nudge the IOL towards the center, towards the opposite side. So that will make, the mark visible. So for those of us who are using a bimanual, at times it's difficult, but with the coaxial, if you nudge it in the opposite direction, it makes it visible.
No, my point is you can use your cholesterol dialer, retract, see the marks, everything. But then after that, after you remove the visco, you're going to hydrate the wound. When you hydrate the wound, sometimes the lens moves, and then you will not know if it's moved. So if you use the toric IOL marker, then you're able to see that the lens is aligned even after you close at the end of the surgery.
Yeah, that point is valid. But for, if you have to see whether it is aligned or not, you can just nudge it, At times
But actually, the trouble actually comes when, pupil is dilated and it's only after putting the IOL that the pupil shut down and you're not already marked. Now, then you are in a fix, I think. So, those situations also are fairly important also. So I think, yes, Sri had that wonderful device, and I think I've done on this really wonderful, innovation. Partha, you would like to add a quick comment, or we move on to the next?
Quick comment, Manpreet, excellent video presentation and very good rundown on the slides. One thing that I do at the end of the just before hydrating the wounds is to put in the irrigation. The viscoelastic has all been removed, and then on the other side using a Y hook just to check whether the alignment is fine. And if it's a markerless system, then it becomes very easy, because with the Y hook you can nudge it also and bring it to the proper alignment. So one hand with the irrigation and the other hand from the other port with the Y.
So thanks, Dr. Manpreet. I'd like to invite Dr. Sindhu, and she'll be talking on better safe than sorry.
Yes, sir. Good evening, everyone. And I would like to thank everyone for the opportunity to present in front of everyone. Today, I'm going to talk about IFIS, it better to be safe than sorry. I'm going to discuss about two cases. My first case is about a 73-year-old male presented with cataract in both eyes, with vision 636 improving to 618 and N10. On evaluation, nuclear sclerosis grade 3 was noted, and pupil dilation was 6 mm in both the eyes. History of hypertensive for past 5 years, and history of BPH and taking oral tamsulosin hydrochloride for the past 1 year. And he underwent femtolaser assisted cataract surgery in the left eye, followed by the right eye. This is a surgical video of the patient. After creating a perfect rhexis and nuclear division with the help of femtosecond laser, the surgeon proceeded with the phacoemulsification. Here the entry was made and injected the viscoelastics. While removing the anterior capsule, the surgeon noted the floppy iris, and he tried to push the iris into the AC with the help of viscoelastics. And the gentle hydrodissection was done. Once again, the iris came out, and he tried to push the iris with the help of viscoelastics. And he used the iris hooks to stretch the pupil mechanically. And once he got the better visualization, he completed the phacoemulsification. The nucleus was removed. And here you can see that here you can see once again the iris came out. He pushed too much of viscoelastics, which ended up in the iris, more iris trauma. Sorry. And he injected the IOL, and the IOL was successfully implanted inside the capsular bag. And then finally the iris hooks were removed. Irrigation aspiration was done. And while coming out of the port, he forgot to turn off the irrigation, and again it causes the iris prolapse. Finally, the iris pushed back and stromal hydration was done, and the wound was closed. My next case is about a 56-year-old female who is on one-eyed, known case of healed choroiditis and presented with cataract. Visual acuity in the right eye is counting fingers, and in the left eye it's 618, improving to 6.9. And both the eyes, nuclear sclerosis grade 2 was noted. Nd:YAG was done for shallow angles, and posterior synechia was noted in both the eyes. And pupil dilation was very poor, and she underwent phacoemulsification with synechial lysis in the left eye. After the side port, the tryptophan blue dye was injected, the entry was made, and the AAC was maintained with viscoelastics. While doing cyanocolysis, the sudden intraoperative floppy iris was noted. Here, instead of pushing the iris with the high-density viscoelastics, the surgeon pushed away the iris through side port with the help of the second instrument. And then the iris hooks were inserted and phacoemulsification was completed as usual. Gentle hydrodissection was done and the nucleus was removed. Since it's a toric IOL, the IOL was centered with the help of the Callisto, which is the markerless toric system. Then the iris hooks were removed. In this case also, he forgot to turn off the irrigation. Again, it causes the iris prolapse. It once again pushed, and then wound was secured with the suture after injecting intracameral myocol. It constricted the pupil and we secured the wound with the suture. My discussion is like both the patients we managed with the iris hooks, but excessive and vigorous usage of the viscoelastics ended up in more iris trauma in the first case than the second case. So the high density viscoelastics used to reduce the floppiness of the iris. Excessive and vigorous usage of the viscoelastics should be avoided. Instead, iris reposition should be done through side port incision to avoid iris trauma. The iris hooks was used to expand the pupil for better visualization. While coming out of the main port, irrigation should be switched off to avoid the further iris trauma or iris prolapse. Intracameral myocol at the end of the surgery, which helps to constrict the pupil, and the wound can be secured with the suture if needed. And oral azithromycin can be given if any early postoperative intraocular pressure spikes due to retained viscoelastics. Thank you, everyone.
Thanks for highlighting those wonderful points. I think a lot of teaching pearls. Can you stop sharing the screen?
Yes.
Professor Boris, I would put in a question to you. Would you prefer ring over hooks in this subset of patients?
Frankly speaking, I'm spoiled by using the ring, so I never use hooks. Theoretically, there is a possibility to use hooks in very limited number of cases, such as when the anterior chamber is very shallow and the anterior segment is very small, when you're struggling to make the chamber deep enough to manipulate safely. Other than that, I frankly speaking, I see no no reason to use hooks, at least when you have access to that. If there is no other option, of course, the hook is another viable alternative to any kind of pupil expansion device.
So if I can add, yeah, so I believe whether it's hooks or rings, none of them have an advantage over the other in reducing the intensity of IFIS. The IFIS, whether you will have iris prolapse or not, depends on the severity of the IFIS. So whether you use hooks, it could be a good day, it could be a bad day. What the hooks or the rings are going to provide us is a constant pupil size to do a safe surgery. IFIS, the prolapsing of the iris, the billowing of the iris is irrespective of your device. You can have it. If it's a bad IFIS, the iris will prolapse irrespective of your ring or hooks in place, or the amount of handling you do. So you could have you may get away with one eye with let's say the hooks, and in another eye you will not get away with the hooks, because it depends. The two eyes may not have the same grade of IFIS also. So the severity of IFIS, which depends upon the dilator muscle atrophy. You see, there are a lot of papers, like Boris also showed in his presentation, that the dilator muscle is thinned out. And then there are other papers also, I think this from Japan, where they showed that the binding of the tamsulosin or with the melanin pigment, that also has an influence on the dilator muscle atrophy. So if it's floppy, it's floppy. If it's a very bad floppy case, the iris is going to prolapse, whether you have rings or hooks. The rings or hooks are only allowing you a constant dilated pupil to finish the surgery.
Don't you think, once the iris is prolapsed, if you see a billowing and you recognize the IFIS, then it's okay to use a ring. But once it has started prolapsing and it started fraying out, do you think at this point an iris hook would work better? Because it will be very difficult to insert a Malugin ring or even your B-hex, and because already the iris is prolapsing. And how is it going to stretch the area where the iris is already prolapsed?
No, if you have to use a ring, you have to have an intact circumference and it has to be inside the eye.
That's
so
exactly.
You just can't get the iris back. So even if you use the iris hooks, you'll have to get the pupil back.
Yeah.
The prolapsed iris, you have to get it back anyway. You have
Absolutely.
to, otherwise you can't go ahead with the surgery.
Yeah, but iris hooks at this point would be better off, like if you go through the wound, like which the surgeon had done through the main port, would definitely be a better option than putting a ring after the iris is prolapsed out of the wound.
You see, the iris prolapses mostly after you've used the device. It's very rare that you have the iris prolapse right in the beginning. If you have it right in the beginning, well, it's your call and you decide with whatever you're comfortable with. I think most of us in our generation, we have graduated from the iris hooks to the rings. So going back one step is not difficult for any of us. All of us, I think, all the faces except for Naren, I think, and Sindhu, I think you're one generation less, or half a generation maybe. Naren is probably half a generation less than us. So we've all graduated from iris hooks, so it's not. But maybe for the younger generations, they should always be versatile. You should try all the devices, and you have to have everything in your store to, armamentarium to, get away with it.
When
Yeah.
I use mainly the rings. Either I use the B-hex or the Malugin, and I have definite indications for both.
Right.
I use the Malugin when I have a rigid pupil, which, because the Malugin gives a little more support and I'm able to stretch the pupil as I insert it. If I have to use a B-hex, then the pupil should at least be about 5 millimeters. If it's very small, like a 3 millimeters and it's rigid, then I have to do a stretch pupiloplasty before I can use it. Otherwise, it's very difficult to insert. So this is because the B-hex is more like a pupil retainer.
Absolutely.
Rather than an expander. So it retains the pupil, but in a very small pupil, rigid pupil, you probably have to stretch it before you actually put the B-hex. That's one thing. My only indication for using the hooks is when I have a small pupil with a coloboma, where I can't use the rings. So that is my indication for using.
How about a subluxated cataract?
What are subluxated?
Subluxated also you can. I prefer to use the capsular hooks rather than the iris hooks, because the iris hooks don't support the equator, and sometimes you can end up tearing the rhexis margin, which makes it worse. So I prefer to kind of support.
What I'm talking of is small people with subluxated cataract. What device would you use?
You can still use the rings. And along with that, you use a hook, the capsular hook, like the Macul hook, and that works. But for the coloboma, you just can't use a ring.
Yes, you can't.
So it doesn't work.
You need a full circumference for the ring.
Yeah. So then that's where you put a couple of hooks and then stretch it in the opposite direction, and then you can do your phaco. A few points which I would like to kind of add: when you have a mature cataract with a uveitic, a small pupil, most of these patients already have an iridectomy. So you can inject a little bit of trypan blue through the iridectomy so that it stains the capsule. And then you put in the viscoelastic and then stretch it. Then you will have staining even under the iris. So that's one small tip that I would like to share. Mature cataract with a small pupil, with a bow down pupil because of Syneque. This is something you can do. And of course, if you're using the rings, you put in viscoelastic, use the rings, then you'll have to paint the surface of the anterior capsule with the trypan blue, and you can do that also. So there's just 2 tips to kind of help stain the capsule.
Thank you, Sri. So now I think we can go on to the last case presentation. Dr. Zain, are you ready?
quick comment from Partha. Partha wants
Okay.
to add
Yeah.
something.
Yeah, sure,
Yeah.
sure. We can.
Yes, Dr. Sindhu's very nice case. Sujata made a very pertinent comment about, the floppy iris popping out from the ports and where it would have frayed. So here, the ring would be difficult to put in because the floppiness would actually billowing of the iris, etc., would actually make it difficult. Here, possibly the iris hooks would be a little better as a device.
So I think, Partha, do you expect it could have been the structure, the architectural, construction of the wound itself? Sometimes you have to actually go and suture back and create a new mail, put a little more material, and then put in a ring, and then you can, do away with that phacoemulsification. Sometimes the wound itself, if the architecture is poor, that could be also one of the causes of, repeated, the prolapse.
Yeah, that's, I think, a very important point, because once you have a prolapse, there is a tendency for the iris to keep prolapsing through that wound. So sometimes it may just be better to kind of suture that wound and then make a different opening than put a pupil expansion device like Sonu said, and then go ahead. That will be less traumatic, and then less depigmentation of the iris.
So thank you. And as we move on to the next speaker, we have Dr. Zain Khatib, and he'll be talking on IFIS made easy with the BHEX. So all two.
Thank you, sir. So I thank AIOS and Dr. Suvin sir for inviting me. So basically, my case is, quite a straightforward case, not as some of the complicated cases we have seen. But essentially, when you are using the BHEX ring, almost every case does tend to become routine. So this was a person on tamsulosin for 15 years, and we expected IFIS. And so when we see a pupil like this, which is kind of mid-dilated, it's bound to go down during surgery. So I always prefer to insert the BHEX ring. So BHEX, goes in through the main wound by holding one of its eyelets. And basically in my video, I'll just be showing how the BHEX can be inserted properly. So once it is entered into the eye, we hold that eyelet and push it beneath one of the edges of the pupil. And then using the two side ports, the two eyelets are again held and inserted beneath the iris. So this is the BHEX forceps being used, and initially I used to try the Sinskey hook, but then the Sinskey did not work out so well. The BHEX forceps actually works really well if you get a good grip of the eyelets. And once once the ring is inserted, the ring generally tends to work as a pupil retainer rather than an expander, and we get a 5.5 millimeter well dilated pupil here. So this now is not going to constrict further, and it serves as a good indicator for the size of the rhexis also. So most of the times I try to keep the rhexis at the margin itself, so that we are getting a 5.5 millimeter rhexis. And once now the ring is in place, the rest of the cataract surgery really becomes fairly routine. I've had very few cases of IFIS where the iris has prolapsed after putting in the ring. But even if that does happen, it's very marginal, and the ring generally tends to work well in retaining the pupil and keeping the iris back in place. So now the phacoemulsification goes on quite routinely. Basically, once the BHEX is in place, every step becomes quite similar, and you get a good visualization of the nucleus as well as of the posterior capsule, what is happening. So just to fast forward. So once the cortex removal is done and we are putting in the IOL, it's important to make sure that the IOL is not touching the edges of the ring, and we are manipulating it such that the ring doesn't get entangled with the the IOL. And the one of the biggest advantages I find with the BHEX over the other rings is that I can do a complete removal of viscoelastic before I decide to remove the ring. This works especially in toric lenses, where I want to remove all the viscoelastic first and then remove the ring under irrigation. So now once viscoelastic is gone, I have my own method of removing the ring. I just enter from the main port under irrigation and disengage the distal flanges, and slowly, one by one, we disengage all. And once it is out, I just, without releasing it, pull it out from the main wound. And, this works well. Sometimes the iris does tend to prolapse, but then, we get a good round pupil at the end. Just to show another very small case, initially I used to try to disengage this lens from the side port under hydration, but then once the lens is disengaged, you can try to get it out from the side port also, but then I just got it, I disengaged all the flanges and then released and came out, and then you see once you want to get it out from the main wound, it's not easy to hold it because of the hydration. The ring just keeps on rotating, and then it's not easy to grasp it. It's such a thin material, that it's not easy, but then once you grasp it, it comes out very easily through irrigation. So yes, those were my two cases. Thank you for the opportunity.
Thanks, Zen, for that nice presentation. Suven, you like to add anything on this?
No, I have seen enough, and I think Zain did a good job. And he did show, and actually, just for your interest, if you go on, Partho was the first guy who showed that rotating ring. If you if you use it under hydration. So since the BHEX is pretty thin and light, and actually that will happen with any ring. If you let go the ring, and your hydration is on, it kind of spins. So if you want to remove the ring under hydration, it's better to under irrigation rather. It's better to hold on to some part of the ring throughout the process till you get it out. Because if you let go, it's going to spin around. That apart, Zain is an excellent surgeon, and I think he showed that copybook style. So we invite comments from others.
Yeah, I just have one tip. When you're inserting the lens and the trailing haptic is lying over the iris and you want to dial it in, then sometimes the ring can get dislodged and go under the iris. So to prevent that, you should go through the side port with a Colested dialer, support the ring and the iris, and use a second instrument to dial the lens in. This way, you will not disengage the ring. Whether it's a BHEX or a Malligan, it can happen when you're trying to dial the trailing haptic in without supporting the ring. So we always support the ring with another instrument, a Colested dialer through the side port, and that's a small tip which you can use.
Yeah, thank you, Sri. And Sri has seen the ring evolve. He's been with me from the prototype stage. Apart from being a great surgeon himself, he's offered some wonderful tips in the development. So the version of the ring that you see, Partho, Sri over here, and there are lots of other people who've used it, and that's I think contributed to the final version of the ring. Thank you, Sri.
And I think the BHEX is an excellent ring if you want to do a femtocataract in a small pupil. Then through the side port you can just insert the ring so that you have a very small incision, and then you can put on the suction so that there's no wound leak. And then after you do the femto, you can make your main incision. So that's the advantage of the BHEX, and I like to use the BHEX when I have a small pupil where I need to do a flex.
So as we come close to the ending of the session, I'd like to invite Dr. Partha Biswas for a good take-home summary and summarize the points. And at the same time, I'll request Dr. Datyal sir to please join us. Yeah, Partha.
Yeah, thank you very much, Sonu. It's been a very wonderful session, and thanks first to Santosh for having designed the session. You guys as the moderators have made it really lively, and our presenters have been wonderful. I think we have seen most of the things under the sun that we should be seeing and take home points from each presentation, I think. So each presentation had a lot of takeaways, and Boris, of course, made a wonderful presentation for every one of us to learn and recapitulate everything that is there. So I think, not speaking totally on the scientific front, but I would really like to say that I'm sure Boris is going to be here with us in 2025 between April 3rd and 6th for the AIOS APAO conference. And we will have a great session, and I'm sure Dr. Namrata and Santosh are making good efforts for inviting the guest faculty from all over the world. And it's going to be a wonderful session for every one of us. And I'm sure IFIS is going to feature with Shubin and Boris in the fray, in the lead. Thank you.
Thank you, Partha. So can we have Dr. Tyal, sir? Dr. Tyal, sir, are you there, sir? So I think he's muted. So Suven, we must extend our heartfelt thanks to Professor Malougin for sparing his time and enlightening us, the entire AIOS, with wonderful tips of wisdom. And I think, sir, we really owe this wonderful device, and we are really grateful for being here and spending your time. And your talk, I think, was really very wonderful for all the teaching pearls. So when you want to add something.
Absolutely. Boris has been a great friend. We've done courses together. We go back a long time. And I must thank Boris for actually changing the course of small people management.
Right.
With his ring, that spurred the interest, and lots of things came after that. But yes, you have to give credit where it's due. And Boris has been a pioneer in this field. The way he thinks, the way he works, it's absolutely amazing. And he's a great friend, and you can ask him a question anytime. Ask him to come for a meeting, and he's happy to join us. Thank you, Boris, for being with us always.
Thank you very much, Suvin, for saying that. And it's always my pleasure to be with you. And I would love to join you next year for the All India Ophthalmology Society, joined with the Academy Asia Pacific. Thank you very much.
Look forward to it. Yeah. Right, Sonu, can we close the session then? Partha, with your time permission?
Of course. I just remembered, there was a speech in which the speaker said that IFIS has been a great proponent in the scientific ophthalmology. It is one instance when an American discovered this problem and a Russian had the solution to it.
And there is another side to it. Whether it's to P or to C. That's what IFIS boils down to. Whether you want to P or you want to C.
Most people like both,
Yes.
I'd like to thank all the presenters, the conveners, and the panel for sparing your time and showcasing your wonderful cases. So thank you very much, and thanks AIOS for this wonderful webinar.
Thank you.
Bye-bye.
Thank you very much.
Bye-bye.
Thank you, everybody. Thank you, and have a good night.
You too. Bye.
Thanks, Boris, once again.